Good evening, good evening. As you all prepare in your plates and have a seat, we're going to get started. This is a dinner reception, and we do recognize that there will be people who will continuously get their meals. Please feel free to partake in your dinner. Misery is optional. Please feel free to enter in and out as you see fit. We're going to start our panel this evening. I am so very honored to have such a distinguished panel with me. This is a panel of what we call an evening with presidents and chairs. So you get to hear from the distinguished members who are president, chair-elects of your distinguished physician societies, and get a sense of what their thoughts are of the day as we've gone through the NMQF Summit. We've spoken about topics such as heart failure, diabetes, prescription drug coverage, payment options, as well as many others. So today this evening, we're just going to bring it all together. We're going to hear a few words from our distinguished panelists, and then we're going to take questions from the audience. This evening's meant to be very much an interactive event. We want to speak directly about diverse populations and the diversity that we've discussed today. However, we want to ensure that you have the opportunity to insert your thoughts, your questions, and your ideals. So I'm going to get started with introduction of our first panelist, and then I'm going to give Dr. Harris an opportunity to say a few words about her position with the American Medical Association. And so I am a registered nurse by background, so you guys have heard the statement, and a nurse will lead them. So here I have all of my, there we are. I know I have the ANA out there. Here we have all of my physician leaders, so I'm going to try to do them justice. So we're going to start with Dr. Patrice Harris. She is the chair-elect at Board of Trustees. She's a physician, obviously by background, who has a diverse set of experiences practicing as a physician with the public health sector, patient advocate groups, and the medical societies. She's active in her career with respect to organization in medicine, and she served on the board of the APA and was also a delegate to the AMA. The interesting thing is that she's held many state positions as well. In the state of Georgia, she served on the board of the Georgia Psychiatric Physicians Association, and she's currently in private practice, so she consults along with her practice with both public and private sectors. So we're going to give Dr. Harris an opportunity to say a few words about herself and the American Medical Association.
Well, thank you. You've heard from me a couple of times, but I will say again, what an honor and a privilege it is to be on this stage with these distinguished panelists. I grew up in Bluefield, West Virginia. West Virginia, I love my state. It's a beautiful state. Please go and visit my state. But it's not a very diverse state. Marcus Welby was my inspiration for being a physician because I didn't see very many physicians who looked like me in my hometown. So luckily there was Marcus Welby. You know, I was thinking, I wonder what I could have been if I had these distinguished panelists as my role models. But certainly it wasn't always an easy path for me. I was the first in my family to go on to graduate education. But I think it's important for us to make sure that the next generation of physicians, of scientists, of lawyers, have role models. They can easily find someone who looks like them. And I will tell you that the AMA, again in conjunction with partners here tonight, is committed to working our way towards that. I'll say a little bit more about this a little later, I think, as we answer questions, but I'm very proud of our work in our Minority Affairs section, and our chair is here tonight, Dr. Neva Lubin-Johnson. She's an internist from Chicago. And the MOS really provides a forum for diverse voices in the AMA's policy-making process. The AMA is a Big Tent organization. It's a very democratic organization. And democracy is not always pretty. but it certainly reflects the best we have to make sure that we are inclusive as we make policy that really affects healthcare delivery, affects physicians, and affects the patients of this country. So I'll be talking a little bit more about MOS as I answer questions. I do want to highlight that one great opportunity that I had recently was to participate on a panel regarding the dearth of African American men who are in medical school. I am frightened by the statistics, and I think, again, we won't solve that problem tonight, but that's certainly a conversation that we have to have. We certainly need to make sure that we have a diverse physician population, but I'm frightened and worried about African American males matriculating up through medical school. I want to also talk about our Doctors Back to School program. That's a program that our MOS team delivers on, and we want to expand that. I hope you stop by the booth. But again, it is an opportunity to go to schools and just be a face so that young kids can see that, yes, I too can be a physician. And finally, I'll just say I'm very excited, and I can talk about this more a little bit later, about the AMA's 3 strategic focus areas, particularly the improving health outcomes. The AMA board went through a very rigorous process to develop a more focused strategic plan, and we decided on 3 areas: improving health outcomes, improving physician satisfaction, and accelerating change in medical education. And I think for 2 of those issues, accelerating change in medical education gives us a unique opportunity to make sure we are discussing these issues about a diverse population that's matriculating to medical school. But our Improving Health Outcomes initiative is really focused on 2 disease states: diabetes and hypertension. And I don't need to tell this audience that people of color, communities of color, are disproportionately affected by diabetes and hypertension. So we are very proud of the work that we are embarking on, along with many of you in this room and many partners on this stage, regarding improving health outcomes, again, particularly regarding diabetes and hypertension. So again, it is an honor for me to be here with you tonight. I look forward to continued dialogue, continued partnership. I hope I don't steal her thunder, but Dr. Edith and I were talking about silos. And it's important that we get out of our silos. And all of us are representatives from very proud, wonderful organizations, but it's critical for us to look for opportunities to work together. So I look forward to, again, working with our partners on the stage, as well as you in the audience. So thank you very much for being here. And as I said this morning, there's a lot of work to do, so let's roll up our sleeves. Thank you.
Great. Thank you, Dr. Harris. I have family in Logan, West Virginia.
Oh, really?
I do,
okay.
but I won't sing the Almost Heaven.
Oh, that don't start. We'll have to do that.
I know you know
end.
the song. Anytime we have more than 3 of them together, we have to sing the Ode to West Virginia.
Right. So is there anyone else from West Virginia? Oh, see, they don't want us to sing.
Just 2 of us, I know. More than 3, so we don't have to sing. Secondly, let me introduce Dr. Edith Mitchell. Dr. Mitchell is she's the president, first of all, of the NMA, the National Medical Association. She's also a board-certified internal medicine and medical oncology and clinical professor at the Department of Medicine and Medical Oncology. She also is a program leader for GI or gastrointestinal oncology at Jefferson Medical College. She is the 116th president of the NMA. Very interestingly, she holds leadership positions at ASCO, the National Medical Association, and she also serves on the board for the Journal of National Medical Association. She has quite a list of achievements. I was very excited and very proud to know that she is a retired brigadier general. She's the first female physician to attain this rank in the history of the United States Air Force. Let's give her a hand for that. Quite an achievement. And just to add to that, just last week we've all heard of Vice President Biden's Moonshot Initiative. So just last week she was appointed to Vice President Biden's Blue Ribbon Committee for Moonshot. So let me give Dr. Mitchell a few minutes to introduce herself and also to talk about her organization, the National Medical Association.
Thank you very much. It is my privilege to be here tonight with my colleagues on the stage and with members of various organizations and everyone here. I very much appreciate the opportunity to speak about the National Medical Association. So the National Medical Association was organized in 1895 when doctors like the ones here on the stage with 2 grams of melanin were denied opportunities to be members of other organizations. At that time, the mission of the National Medical Association was to foster those influences of healthcare, basically for blacks in this country. Since that time, the NMA's mission has expanded to other individuals, other races, other ethnic groups, so that we're focused on healthcare for America. And with that, we cross many different nationalities for many different individuals of varying backgrounds, for physicians and providers, but also for the patients that we serve. So it's all about healthcare in the United States. As our healthcare and our populations increase more and more, it's necessary that we all focus on healthcare for America. So the NMA has worked with the American College of Physicians, with the American Medical Association, and other associations, because we all want to make sure that we're moving in the right direction and all moving in the same direction. The NMA has been involved with breaking those barriers to healthcare research and delivery over a number of years. And this year we decided that we were going to change a little bit, and I added a little military information in there. So we have moved past identification of the barriers, and what we want to do is true north toward healthcare equity. And you ask, well, what is true north? If you can imagine, this is a military term. If you can imagine a straight line between the South Pole and the North Pole, and you need to go from one to the other, we know that the topography of the Earth is not a straight line. And we know that if you're moving in a direction and you're using a regular compass, that won't get you where you need to go, because there are mountains, rivers, and other challenges that could impact your direction and throw you off key and off the path. So in the military, we have a term that says true north. And with a true north compass, actually, no matter where you're located, no matter where you have to leave for a challenge, it tells you where you are and what you need to do to get back online, moving toward the direction. So we say true north. And what we want to do is know where we are, first of all, and then secondly, know where we're going, so know what our goals are. And then third, if we meet a challenge and we're thrown off course a little bit, we need to know what we need to do to get back to our goal and where we're going. And that's what we need to do with healthcare. We need to work together, break the silos, know where we're going, and know what resources we need in order to get there. So that's one of the areas that the National Medical Association is working with this year, that is breaking our silos so we're all working together. We want to know where we are at any point, and we want to know what we need to do. to achieve the goals that we need. The NMA has been really big this year on setting our goals. One of those is making sure and ensuring that individuals have access to medical care. This is the 50th anniversary year of Medicare, and the National Medical Association was very, very important in establishing the legislation and supporting then President Johnson. And many of us don't know that when President Johnson signed the Medicare legislation, he went to Independence, Missouri in order to do that. And the president of the NMA, Dr. Cobb at that time, was invited along with the president, and he was present at the signing of the Medicare legislation. This year, the NMA has been very involved with CMS to try and increase the number of individuals who took advantage of the marketplace in regards to ACA and in getting insurance so that we can increase the number of individuals in this country who have access to medical care and therefore coverage. So that has been one area. Another area that we are supporting is that of our, and I don't say aging anymore as I grow a little older, but our population in the United States is aging, and therefore we have to support not only the medical care for the elderly population, and we can all say the more mature and the more experienced population, but our physician population is also aging, and and our individuals are working later in life and are very capable because of improved health care. So working on populations, bringing everybody together. Another is violence in the neighborhood. And we all know the impact of violence on mental health, stress, and others, but we don't realize that there are other influences in the community that are very important as a result of violence. Number one, nutrition. When communities are affected, stores are closed, there are so many areas where one cannot obtain fresh vegetables, fresh fruits, because they're not available. They can't even go to the drugstore, either because the drugstore doesn't exist anymore or because people are afraid to obtain their medications. So there are other impacts of violence, and that's a part of what we're doing. Prescription for exercise and trying to prevent the complications of a lack of exercise and obesity, another, and medical education, and therefore breaking the silos so that we're all working together, whether you are a medical provider, a patient, or someone else. It's making sure that we all have the access to care and therefore can take advantage of the opportunities, and therefore we can look at our goal and say we want healthcare equity. And let's stop talking about the barriers. We all know a lot about barriers. We need to move where we're going and make sure that our patients are going there with us. So I thank you. I'm very happy to be working with this group and these distinguished physicians and healthcare administrators, teachers, and others. So thank you very much.
Great. Thank you, Dr. Mitchell. I think your comments on the True North truly resonate, because I consider the National Minority Equality Forum sort of that true north for us when we're speaking about sort of diversity in the population. And then I think all of us individuals have to figure out where we are, like where's our true north? How do we ensure that we have access and continued increased awareness of diversity within the work that we each individually do? So I hope we all take that challenge and sort of that one piece of factoid from the military, from our Brigadier General there. I do have a family member in the Air Force. I'm going to start speaking about the True North. They're going to think that it's sort of like when I talk to my husband about basketball. He tells me no. I do know about Steph Curry, though. So next, I'm going to introduce Dr. Wayne Riley, who's the president of the American College of Physicians, the ACP. Dr. Riley is a native of New Orleans. He's one of our nation's most respected and accomplished physicians. He's the 91st president of the ACP and serves as a leader of the professional home for all who practice the specialty of internal medicine and also the subspecialties. Founded in 1915, ACP is the largest medical specialty society, and I hope that Dr. Riley will tell us a bit more about that in a few minutes. In addition to his ACP responsibilities, Dr. Riley is also currently serving as clinical professor of internal medicine at Vanderbilt University School of Medicine, and he's an adjunct professor of healthcare management at Vanderbilt's Owen Graduate School of Management. He is a member of the prestigious Institute of Medicine. I always wondered if we knew anyone on the IOM. He's now formally known as the Academy of Medicine, where he serves as the chair of the Administration of Health Services, Education, and Research section of the National Academy of Medicine. Dr. Riley.
Thank you, Stephanie. Delighted to be with you. Delighted to be with you on my capacity as Stephanie said, president of the largest medical specialty society in the United States, second only in size to Dr. Harris's organization. The ACP is a 145,000 member organization representing internists. I'm a general internist. Those of you who don't understand what a general internist is, there's a TV show called House. I am House without the ethical problems and the other things. So we're the medical detectives. When you present to us, we use our powers of examination and physical diagnosis and testing to figure out what's wrong with you. So it's quite an honor. The ACP, as Stephanie mentioned in my bio, was founded in 1915. And I can assure you in 1915, there were no members of the American College of Physicians who looked like any of us up on this stage. And it wasn't until the late 60s, through the work of the National Medical Association, who was agitating that all the other major medical organizations begin to reflect American society, that the ACP began to welcome African American, Latino, and women physicians, by the way. It was pretty much a white male organization for its first 70 years. So if you think about it, I'm the third African American president in 100 years, but for the first 70 years, it would not have been possible. So I take that high obligation quite seriously in terms of my work to advance the health of the American public, and to also not forget that as part of our work to advance the health of the American public, that we're focused on issues of health equity and disparities. And I'm very proud to say, as I said earlier today, the ACP has been a very progressive mainline medical organization. We put out policy on health disparities probably about 14 years ago. We put out policy last year on addressing LBGT health equity. We put out our landmark paper on firearm violence in the country, of which the NMA and the AMA were participants. I'll be back up here on Monday for a national press tour to talk about climate change. The other thing about my role, I have been on the road constantly, like all the presidents, but in the past 60 days, I've been to the United Arab Emirates, Brazil, just came back from India last Thursday. And part of the other thing in terms of our work is we have to begin to think about health as being global. Many of the things that we care about here in terms of health care are existing in other parts of the world. And again, we have 18 chapters of the ACP around the world. And so I've been traveling internationally quite extensively in addition to spending a lot of time here in Washington. This is important, colleagues. What we do here is very important. Sometimes we look at the daunting challenges of health equity and think that we have not made progress. I can assure you, and so as all of my colleagues on the stage, we have made progress. And a lot of it has happened within the past 5 years with the Affordable Care Act and our wonderful President of the United States and what he did, putting his political career at stake by pushing to change and to extend health care to all Americans in a better way. But if you think about it, Edith mentioned President Johnson. I think he has been an amazingly unheralded advancer of minority health. If you look at the legislative history of Medicare, which we just celebrated the 50th anniversary, Medicare in some parts of the South was opposed by the Southern senators because they knew that, well, if we gave Negroes the ability to go into any hospital, that would be a problem. And so it was President Johnson, with his amazing skills at persuasion, who pushed the Medicare bill through the Congress. And again, it began to show effects in terms of African American, Latino, and Asian seniors getting the same level of care as other parts of the country. So history is very important for health care, and that's one of the things I spend a lot of time with my students, is making sure they understand the historical context for health progress. And I do think that's important for us to look at those lessons as we work on issues of today. So I look forward to our dialogue very shortly.
Great, thank you. I'm going to come back to your point about not only the global sort of perspective for healthcare, but also history being a very important part. It's interesting if we think through sort of cyclical progress and cyclical issues that occur, what can we learn and how can we apply them as we move forward? So I know that someone on this table over here had a similar question that we're going to ask. Next, I'm going to go to Dr. Kim Williams, one of our presidents of the American College of Cardiology. Dr. Williams received his undergraduate degree from the University of Chicago, followed by medical school at the University of Chicago. He has fellowships in cardiology, clinical pharmacology, and nuclear medicine, all obtained again at the University of Chicago. He's board certified in internal medicine, cardiovascular disease, nuclear medicine, nuclear cardiology, and cardiovascular computed tomography. He serves as professor of medicine and radiology and a director of nuclear cardiology at the University of Chicago as well. He served as the past president at the ASNC and chairman of the board of ABC. He's also served as on the cardiovascular disease examination board of the American Board of Internal Medicine. Dr. Williams previously served as chair of ACC's Cardiac Imaging Committee and a Cardiovascular Imaging Collaborative. He is on the Coalition of Cardiovascular Organizations and the Cardiac Imaging Council. He's also been an ACC delegate to the AMA since 2000. Can we hear a couple of words from you, Dr. Williams?
Well, thank you, Stephanie. And it's really a pleasure and an honor to be here with all these luminaries and leaders in the field who have really shown the ability to attain the aspirational target of leadership and scholarship. And so thank you very much for all that you've done. It's my pleasure to represent the American College of Cardiology. It's a 53,000 member organization, about half the size of, if we can compare notes. Turns out we have twice as many international chapters.
Right, that's right.
Which actually becomes my first talking point. We have 36 international chapters, 50 domestic chapters. And why would we have so much international activity at the ACC? Well, it turns out that if you look at the statistics, cardiovascular disease has been the #1 killer of Americans since 1918. It was supplanted for 2 years by the Spanish flu epidemic. And it is essentially a cultural illness. It's a foodborne illness. Don't stop eating what you're eating. If you're eating animals, you might think about it. And it's lifestyle. And so what's happened is we have exported from our country to other countries, and imported some as well, a lot of cultural laxes in terms of exercise and conveniences in terms of high-fat food that's easily obtained. And this actually has increased cardiovascular disease to be the #1 killer around the world. And so that is really what's engendered so much interest internationally in our society. And we try to go in and try to deal with whatever's going on. And there's a lot of hypertension in Colombia and a lot of heart failure in Brazil and heart attacks where people cannot get that nowhere close to a 90-minute door-to-balloon time in Argentina. And everybody's got their own problem, and we try to help. We learn from them, and we partner with them. Domestically, we have been on a mission this past year. I kind of thought that growing up in Chicago and being the first African American that people would talk about, first African American president of the ACC, or because I have like $4,000 career prize money as a professional tennis, they'd say this is the first professional tennis player to become the ACC. No, that's not what they talk about. They talk about the first vegan president.
That you are.
And that I am. And the reason they talk about it so much is that we have been on a mission to, as part of our strategic plan that came out a couple of years ago, to push population health. When you start thinking about it for a second, you immediately say, you know, cardiologists pushing population health, pushing prevention to decrease their income. It doesn't seem to make sense, but it actually does. And we have not gotten a lot of pushback from our membership about trying to lower their income by doing the right thing. We actually have put on some very provocative displays of our intent to try to improve the health of Americans and folks around the world with a population health convention that we put together at Hart House around the corner and down the street. Had luminaries such as David Nash from Jefferson, who was a wonderful guy. He actually is like dean. He created the first Department of Public Health at Thomas Jefferson. And he's a very insightful guy. You know, his famous quote, I have to repeat it, no outcomes, no income. And that really is the future of what we're facing in terms of MACRA and making sure that we are measuring what we do and do it better and try to take care of people and be paid to take care of improved outcomes instead of just, you know, doing more CATs or doing more nuclear, you know, or CT of the heart. And so we have partnerships with Health and Human Services now, and the White House, especially with Michelle Obama. I have to give her a lot of credit for the fruit and vegetable. It's a big laugh if you ever Google Michelle Obama and Jimmy Kimmel. I won't talk about it now, but you'll just get a kick out of it. But they're very serious about, you know, let's move. You know, maybe people didn't move enough, but changing the diet, and particularly starting early, so that we can prevent the heart disease. Because what most folks are not aware of is that on the American diet, 3-year-olds end up with plaque in their arteries. And it's really time to try to change that. Everybody needs to be having the habits of exercising, knowing what their blood pressure is, knowing what their cholesterol is, not smoking, and having a healthy diet with low-fat, low amounts of animal products. And if you look at the American population, how many people actually do that? It turns out about 3%. So unless we get a hold of this epidemic, we are really not going to move the needle. And so we really have been trying this entire year. All kinds of battles have been fought with a lot of the partners that we have up here. You know, the dietary guidelines is a great example where they had some things that were good and some things that really needed to be clarified, and we try to work with the USDA to try and get Americans to eat healthier. So it's a different space for the ACC to be in. We're normally doing, you know, guidelines and education and digital products to try to improve cardiovascular care, and we're still doing that. And we're still producing, you know, when do you put in a pacemaker and the like. But we have bigger aspirations now, and that is to try and turn back this tide, both domestically and internationally. So I really appreciate the partnership of everyone that's up here. You know, we've had a lot of things that we do with ABC. I should talk about that for a minute. One of the things that we do with ABC is Spirit of the Heart, where you go into a community and you do screenings. And if people know what their blood pressure is and they know what their cholesterol is, and everybody has the ACC-AHA ASCVD calculator on their iPhone? Mostly. If you don't, please download the app so that you know what your risk is and you can do it for your patients with just the blood pressure, race, gender, et cetera. You put the data in, and it tells you what the risk is. And that person's treatment should be, and their diagnostic workup could actually be pretty well established by knowing what that risk is. So going into communities, it started with ABC with barbershops, but now we go everywhere, to churches, go places and find the people before they have the disease. It's a completely different you know, way of doing things than what we've done in the past. And I think under Obamacare, particularly with the change in with MACRA, and I hope everybody recognizes how well President Obama pushed for us to get the SGR fixed. Okay, the SGR, I'm not sure everybody remembers because it was a year ago now. It's like out of everyone's mind. But you know, we were all going to take a 21.4% cut in Medicare reimbursement, and it didn't happen because we all partnered together and went to the Hill and talked about creative solutions, including more registries and more responsible care. And you know, we have quality metrics instead of a big cut. But now we have to live up to those quality metrics. And so, you know, we have to do more screening. We have to do more education. I do want to touch on one issue that has been vexing to me is that we really have not solved in cardiology the issue of how many black cardiologists can we get. And the cultural sensitivities are really important. We still have some major disparities. African American men have improved in terms of cardiovascular mortality, but the improvement is substantially less than the other segments of the population. And you might have seen the publication in the last 2 days that it's really about economics. That is, poor people have actually not improved. Even though everybody else is improving their longevity, poor people have not improved their longevity at all. And so we're feeding into that. Part of it is lack of healthcare providers to which a patient can relate. And so what I'd like everybody to do is to just volunteer to go to the 5th grade around your community and talk to inner city kids about heart health and heart science and medicine in general. If you're able to do that, you can actually change the needle. You might be able to get some more healthy behaviors in the fifth graders moving up. That would be great. But to get some of them to think about having an interest in math and science so that they can then go on to medical school and be prepared. Without that, we're not going to turn this tide around nearly as quickly as we should. So with that, I'll end, and hopefully we'll get to answer some questions. But I appreciate everything that everyone in this room is doing to try to improve healthcare care disparities. We have a long way to go, and so I'm glad you're here. Thank you very much.
Great, thank you. Thanks, Dr. Williams. It's interesting, your statement with no outcome, no income, because we did receive a question, I hope we have a chance to get to it, about the increasing number of policy provisions that are now required for physicians through the Medicare program. You have, to name a few, the EHR, the meaningful use, you now have value-based modifiers, and then MACRA's coming. So one of the questions was pertaining to the challenges that physicians are going to face and are facing with these numerous sort of quality initiatives and metrics that we've asked for and we need, but also how do we balance? Right. So lastly but not least, let me introduce Dr. Barbara Hutchinson. I've wrote on my notes here, Doctor, because she has a PhD as well as an MD, and she is the president-elect of ABC. Dr. Hutchinson is a managing partner of the Chesapeake Cardiac Care. She was born in Tobago, West Indies, and received her Bachelor of Science degree from the University of West Indies in Trinidad. And she had a childhood curiosity about heart disease in her father's family, which led her to come to the United States and pursue a career in cardiovascular disease and management. So she completed her PhD in cardiovascular pharmacology at Howard University. Some say that Hampton University is a real HU, but I won't go there. Just saying. Dr. Hutchins she has presented many papers and lectured nationally and internationally. She's a member of several medical associations, which include the ACC, which I had renamed earlier, the ACC, the Association of Black Cardiologists, the American Society of Echocardiography. Away from the office, Dr. Hutchinson is an excellent cook. She specializes in preparing healthy meals that taste well and do not compromise cardiovascular care. She's also a musician, and being from Trinidad, the home of the steel plant, which I have tried to play once with no good, it's one of the instruments that she plays well, and she's also part of a band there. So very diverse indeed. Dr. Hutchinson.
Thank you. I'm really honored to be in the presence of all these more, I would say, mature organizations. I was sitting here thinking, wow, we are the youngest, but I'm happy to report tonight that we are out of Pampers and we are actually at university. The Association of, first of all, I would say that I'm honored to be the 16th president of the Association of Black Cardiologists, and I've actually been in this role exactly 9 days.
Wow.
The Association of Black Cardiologists started approximately 42 years ago when cardiovascular specialists attending the American Heart Association meeting in Dallas came together, and it's the first organized group of cardiovascular specialists really to address the heart disease that was so prevalent in blacks. And in the last 42 years, we have been on a mission. And the mission is really to educate and to educate and also to prevent to prevent heart disease, including stroke in African Americans. And we've been using 3 main pillars to do this. One of which is research. We all know and we all say that there are not enough blacks enrolled in trials. Well, we believe it's one thing to say it, but we need to do something about it. And so our organization has done studies to identify what are some of the reasons why a lot of blacks are not enrolled in trials. And in our question, in some of the questions later, we'll go further into that. But that's one thing that we are now having tools, not just for the patients, but for the patients, for the clinical investigators, and as well as for other physicians that are doing clinical trials to minimize some of the barriers. We also, as far as research, we have recently embarked on a program with the Morehouse School of Medicine and the American Heart Association to develop a registry that involves minorities, and we'll hear more about that later. So that's one pillar, research. The second one is education. And we just don't educate other physicians, but we educate the community. You just heard about our signature program, The Spirit of the Heart. That's usually a 3-day program in different cities across the country. And the first day we involve locals, it could be politicians, it could be clergy, and just individuals. On the second day, there's the screening day, all day, where we screen for different risk factors for heart disease. And on the third day, as you know, African Americans, they may not go to the doctor, but they go to church. And so we have, from the pulpit, we have a message talking about the importance of taking care of yourselves. So that's the education. And finally, our third pillar is advocacy, because it's important to get in front the necessary people to make your voice heard, and we try to do that. Our organization is just about 1,500, and it includes physicians, it includes community leaders, their corporate partners, and we hope to have institutions, because there are a lot of institutions across the country that treat minorities. And so far, there are not many that are part of our organization, but that's one thing that we hope to correct. So I'm really honored tonight to be in the presence of all these organizations that we've worked together with, and our founder, Dr. Richard Williams, who I think is in the audience somewhere, who is soon to be the president of the National Medical Association. And we would continue working closely with that group, as well as the American College of Cardiology that we've worked with in the past. And I thank you.
Great. Thank you. And you said your founder of ABC is in the audience, Dr. Williams? I don't see him. Let's see.
Right there.
Where?
Right over here.
Yeah.
Let's stand. Where are you? Congratulations. Great. We're going to now open up to question and answer. So I'm going to start with a question, but those of you who have questions yourselves, if you can go to the mics, and that way you'll sort of be on deck as we begin the Q&A. And if I have anyone that's at the mic immediately, as you're going to the mic, I'm going to point out my tables here with questions here in a second. So the first question I have is that diversity, and especially diversity and inclusion, is sort of the highest that we've seen in recent years. Have we really done a lot to move the needle Like, do you really have you found that there has been progress? Is there something more that we can do from the seats that we're in with various healthcare initiatives? Like, what's our call to action? Anyone want to address that question?
Yeah, in terms of healthcare professionals, it's sort of a yes and no answer. My late father was a physician. When he finished medical school in 1960, I think maybe 2.5 to 3% of all physicians in the United States were African American. Today, 4%, 4.5%. We've only gone up a percentage and a half in almost 50, 60 years, so we still have problems. Nursing is the same way, only 6% of nurses. On the Latinos, same issue. So we still have a long way to go. Last May, there were about 13,000 new MDs that walked across the stage. Only about 1,000 of them, or 1,200, were African American. Only about 1,400 were Latino. So we still have huge issues, colleagues, in terms of diversifying the health professions. So the other aspect of this, too, is that we have to be pragmatic and strategic. And we have to seek out professionals, even if they're not minority, but they have a reputation for taking care of minority patients well. And we know many of those physicians in many of our communities that our communities know intrinsically treat them well, give them high value care, et cetera. So, you know, it's sobering news, but we still have to work on it. It's an issue of K through 12. I think someone mentioned K through 12 is really the action. The very few numbers of African American males in medical schools. I had the honor of a lifetime to lead Meharry Medical College for 7 years, and I never forget, I asked for an admissions report one day to see how our admissions process, and it was about this time of year. Meharry admits about 130 students a year, and there was only 8 African American males accepted. And I thought it was a typo. I thought it was 1-8. I called the admissions director. I said, "Hey, I'm just double checking. This is that 8 or 18?" She said, "No, Dr. Lai, that's 8." And it's reflected in all professional lives. You talk to lawyers, same problem in law schools across the country, architecture programs, et cetera. So it's not just medicine. So African American males are missing in professional life in general.
Great. Dr. Hutchinson?
I think one of the things that is why I think we're not moving the needle is that if you're talking about diversity, let's take an institution, for example, whose mantra is diversity. It needs to start at the top, because if you're going to talk about diversity, you should have some diversity in your leadership. And sometimes as we look across the leadership of some of the institutions, there isn't that diversity, and you wonder, how could you be talking about diversity if you're not inclusive? So that's one thing, and I think that's an issue that we need to address, just being at the table more.
Great. And Dr. Williams, and then we'll go to the mic there.
Sure. Just wanted to comment that there are some places where folks are focused, really trying to move the needle. Rush University, where I happen to be the chief of cardiology. I'm happily the chief of cardiology there. Proud to be with that institution. Had a long storied history of not being inclusive, 40, 50 years ago, but now they really are turning that around. And there is an adjacent junior college, which is almost all African American, some Hispanics, Malcolm X Junior College. They've actually set up a program which is basically a tunnel or a funnel. I guess it's probably more like a funnel than it is, or a tunnel than it is a funnel, where the Rush University, which doesn't have a college, it just has professional schools, social work, medical, nursing, that sort of thing, and School of Medicine, where the students are encouraged to apply, and they can actually go through as a seamless transition from one to the other to try to get in all aspects of healthcare. And so I think it sets a model, and I think there are others around the country that do things like that, where a so-called majority institution would try to focus on the community that's surrounding them and try to lift it up. And so if we could just make sure that is reproduced in other places, I think we'd all be in much better shape 10, 15 years from now.
Great, I love that. We'll go to the mic for a question.
Hi, Cynthia Hernandez, counselor from Families USA, Director of Health Equity. When my father was a family physician, and when he retired, faced the same thing. He could not find any doctor, let alone a Latino, Puerto Rican, Spanish-speaking doctor to deal with like a town where they had 30,000 Puerto Ricans and no Puerto Rican doctor anymore once he decided to retire. So all these efforts to increase the diversity of who goes into medical school are really essential. But my question is, like, that is at most a 10-year plan. You know, at the shortest, a 10-year plan, right? Or even longer. What do you suggest should be done in the meantime, especially when you read articles like the piece that just came out about all the myths that, you know, current medical students think about African Americans? It seems like people have been talking about sensitivity training and diversity training for as long as I can remember, and I'm not clear that it's actually making a difference. So what can be done to address, what do you suggest be done to address these cultural competence issues that are so central to ensuring better outcomes?
Great. Anyone like to take that? Great. Go for it, Dr. Mitchell.
So, for cultural competence in our institutions, it really requires a large amount of planning, and planning from the top. We need to see more physicians on the medical staffs and leading our institutions. We need to see more of the institutions reaching out. There are many institutions doing something, so we have come a long way. We've got another long way to go in terms of reaching the population, making sure that our medical institutions recognize the population that they serve and that they have appropriate programs for them. Some of this has been required by agencies. For example, the Joint Hospital have required, and they actually have a map toward cultural competence that they advise hospitals and medical institutions in the country to follow. And I can tell you, when the Joint Commission comes to your institution, they certainly look for those programs that follow that roadmap. It's also related to individuals in the community, so that the institutions are working with the community. Every community is different, and there's no one shoe fits all that applies to all institutions across the country. So it's really the healthcare institutions knowing the community and working with the community to ensure that there is equity in healthcare.
Great. Dr.
And I'll just say one last thing, is the other is to share best practices. I'm certain there are programs out there that are working and others that may not. And where is the repository of information that folks can go to know what's working? Actually, someone came up to me early today and shared a great ideas during the simulated learning in medical school. They have, if they're particularly in an area where there's not a diverse population, they make sure those folks come in from the community and make sure the medical students and the residents have an interaction with them in those sort of patient simulation situations. So I think it's where are the best practices, what are the best practices, and how can we make sure that knowledge gets shared across all of our institutions and communities.
Great, thank you. I think we have a question at the far mic.
Thank you. Taman Osborne Roberts, family physician in Colorado, immediate past president of the Colorado Medical Society, executive consultant and futurist. I'd like to first of all thank all of you for coming and telling us so much about the things we can do and being an inspiration to us all. You've already talked about what we can do inside of really our own communities, and I want to move that to really some of the communities outside. We're living in a very unique time. There are a lot of dangers for the country, but there are a lot of opportunities because of those dangers. We heard earlier today that the war on drugs is extended not simply, mostly to communities of color, but also to communities outside of that now. Millennials are starting to feel the oppression that many of our communities have felt, not simply within our communities, but in what is currently the majority, but is rapidly becoming simply a plurality community, the Caucasian community. We're in a place where we're in an unprecedented opportunity to partner with the community of Caucasian Americans, European Americans, to maybe begin to move forward. What I want you to do is tell us a story. Give us an image, a narrative, an ability for how we move, outside of partnering within our own community and strengthening our own community to partnering with what is currently the majority, but will not remain the majority community of the United States, to move towards a place of equity, a place where MLK's dream that our kids would all play together and have equal opportunities is true. More, because not simply because it's the right thing to do, but because it's a simple necessity of where the country is going to go.
Great, Dr. Hutchinson.
Yeah, I think that is. I like how you explain that. But I want to share with you what we actually did in the Association of Black Cardiologists. Several years ago, we talked about the pipeline. There weren't enough minority cardiologists being trained at institutions. And what we did is we had a wall of shame. That is, institutions that had never trained a single cardiologist. And we said to them, look, you've never trained a single cardiologist. And we had a program where these institutions then moved from that wall of shame to a wall of fame, because they turned the whole thing around, and it was all by bringing awareness to the problem. And for them, they probably had never thought of it. And one of our stellar institutions, it was really heartwarming recently to see a picture from that university where the patient, the physician, the assistant, and the fellow in a cardiac catheterization lab were all minorities, coming from an institution that previously had never trained a minority. And in terms of partnering, we also have a program with majority institutions where they train our fellows. So and it has worked very well for us over the years. So I think it can work, but bringing awareness first and having them see that they can make an impact in terms of closing this gap of disparity.
Great. Anyone else like to address that question? Thank you. We'll go to the mic here for another question.
Hi, Alice Coombs from Massachusetts. I have a request. You can help me. The Task Force of Prevention has come out with so many bold recommendations that are sweeping. The consideration of public funders is such that when those recommendations come out, that is a rationale not to pay for them without the consideration with the subgroups for which it is clear that they're at greater risk. The latest is the PSA, for instance. And so there are people around me at tables that are saying, well, Medicare shouldn't pay for this anymore, as a blanket statement to correspond with the task force recommendation. What I would like to see is to work backwards from African Americans, Latinos, for things that we should form some kind of rubric or framework for which we can have an argument at the table for funding workups or screening for African Americans and Latinos or Laotians, specific groups that have a propensity to develop more aggressive disease. There are some people who are nihilistic to the point of why treat cholesterol? And these are people who are well recognized as national experts, even the editor of a major journal. And so I know the task force has come up with those recommendations because of harm associated with testing in terms of workup and especially cost. But if each of the organizations could some sort of way come together with a consensus paper, something to give ammunitions for those of us who are working in the public sector for public payment, it would be incredibly helpful. So I don't know if your individual organizations have crossed this road, but it's a hard thing when there's nothing out there from the organizations that says, let's just take it from the standpoint of these people at risk, subtract them, and let's do a campaign for this subset.
Right. I think Dr. Williams had a comment.
So thank you for bringing that up. I think we've talked about some of this at ACC, but It's not something that we can do alone. It's something we would have to partner with everyone. The talking points that I like to give are started in 1986 with EMTALA. Everybody remembers what that is? The Emergency Medical Labor and Treatment Act.
Absolutely.
Which meant that everyone in this country could get care in an emergency regardless of ability to pay. Well, if you don't prevent the strokes, if you don't prevent the acute renal failure from hypertensive crises, who ends up in the emergency room without the ability to pay? And then who pays for it? So I go to the majority people and say, if you help us, if we invest the money in prevention, then you don't have this tax burden, okay, of taking care, because not everybody dies when they have the stroke. Not everybody dies when they have class 4 heart failure. They don't die right away. They have a very expensive government-mandated exit that we could actually prevent with some attention. So why not develop programs, as you're suggesting, where we focus on new guidelines, on community screening, where we identify people who are at risk, spend the money up front, and save the money on the back end. And so, but it'll take really, these are not all heart diseases. You know, I happen to know after my dad died on dialysis, I kind of like got into it, and cardiorenal, and one of the most fascinating statistics is the $87,643 per year per dialysis beneficiary. And everybody knows that the moment you're on dialysis, you qualify for Medicare. Right. Where's that money coming from? It's coming from the people who have the jobs and the income, which is mostly the majority population. They're paying for this. And so the fact of the matter is, we could actually, if we point this out and get enough leverage behind it, we should be able to partner together and get the funding that we need for research and screening and early treatment and really make a difference. And so I would say, put us all together, put all the organizations together, and see what we can come up with.
Absolutely. I've been a big proponent of breaking silos so that we're all working together. My last job in the Air Force was a Joint Services Commander. Nobody had ever heard of it at that time, but I was responsible for a large group of Marines, Air Force, Army, and others, and really breaking the silos so that we all work together. Now you see them on CNN, and you can't tell the difference of who is who. And that's what we have to do in medicine. The preventive strategies for cardiac disease. As an oncologist, they also prevent cancer. Right. Smoking cessation or smoking prevention not only affects cardiology, but it affects cancer, and consequently, the cost of cancer care in this country has increased tremendously. If you look at prostate cancer now, we have one treatment that costs $193,000 for 4 weeks of treatment. So we can prevent many of these disease processes from actually becoming diseases by our preventive strategy, and consequently that can save money on the treatment end. So it's really all of us coming together.
Great.
But I think in addition to us coming together, I always like to think that there should be 4 P's present. The patient, the physician, the payer should be there, as well as the policy makers. Because I think for us to really move the needle forward, all 4 P's need to be at the table.
Great. And we have just under a minute left, so we're going to start on time and end on time. So I'm going to ask Dr. Harris if he could just give us your last comment, and we'll close the evening with that.
Well, I just wanted to say, you're a P of patient and public, because it is going to take us coming together, but we have to also make sure that there is a different culture about healthcare seeking. Because folks, I think, are in the habit of, unfortunately, perhaps waiting.
That's right.
And so it really is a paradigm shift to go in early and to eat the vegan diet. I'll try that. I'll go get that. So I think it's
convert one person
that's
per
an
room.
important key, and it's about educating. It's about a culture shift in how to help seek, and that we should not expect folks to just suddenly you have health insurance and just turn it on. Now they know how to navigate a new system. So I think that's a critical piece of it.
Great. Thank you so much. If you all can join me in saying thank you to our distinguished panel. I think it's quite an honor to have moderated a panel with such distinguished guests. I mean, thinking about our presidents and chairs of these prestigious organizations, I don't know when we'll have this opportunity again to get them together. And thank you to Dr. Puckering for putting this panel together for the NMQF. Good evening, everyone.